Hi there, my name's Edwin De Kock, and I'm going to be discussing colon cancer for my chronic disease project. So, starting on slide 3, the introduction. Colon cancer is cancer of the colon or the rectum. It is the second greatest cause of cancer death in the United States, second only to lung cancer. There are around 150,000 new cases in the U.S. each year. Each year, around 50,000 people die of colon cancer. Effective screening for colon cancer has been shown to significantly decrease mortality. Globally, the regional incidence of colorectal cancer varies greatly. The highest incidence rates are in Australia and New Zealand, Europe, and North America. The lowest rates are found in Africa and South Central Asia. Geographic differences seem to be due to differences in diet and environmental exposures. Low socioeconomic status is associated with an increased risk of developing colorectal cancer. According to CDC statistics, in the U.S. in 2017, there were 140,000+ new cases of colorectal cancer reported, and 52,000+ people died from it. For every 100,000 people, 37 new CRC cases were reported, and 14 people died from it. Incidence varies by race and ethnicity, as seen in this graph. And I'm looking at the graph on slide 7 here. And going to slide 9, we're talking about San Bernardino County. Incidence of CRC in San Bernardino is high compared to other California counties. Only Glenn County ranks higher. There were almost 3,800 new cases of CRC in San Bernardino County from 2013 to 2017. This equates to 39 cases for every 100,000 people. Over those years, 1,430 people died of CRC, or 16 per 100,000 people. Now going to slide 12, cause. Colon cancer is a result of mutated colon cells proliferating in an uncontrolled manner and forming tumors. Eventually, these tumors spread to other parts of the body. Cell mutations can be inherited, as seen in colon cancer syndromes such as FAP, familial adenomatous polyposis, or Lynch syndrome. Or these cell mutations can arise during tissue development, or sporadic mutations. Potentially modifiable behaviors such as physical inactivity, unhealthy diet, smoking, and obesity are thought to account for a substantial amount of the socioeconomic disparity in risk of CRC. Now, slide 13 shows you a picture of the adenoma carcinoma sequence, or how these mutated colon cells will first form adenomas and then carcinomas. Now going to slide 14. As we will see below, there are modifiable risk factors to developing colon cancer. If someone lives in an environment where those risk factors cannot be easily avoided, it is reasonable to believe they would be at increased risk of CRC development because of their environment. Now going over to slide 16. Several genetic disorders such as familial adenomatous polyposis and Lynch syndrome carry a very high risk for developing colon cancer. Even outside of these specific genetic syndromes, family history is an important risk factor for developing CRC. Having a single first-degree relative with CRC increases the risk approximately twofold over that of the general population. Having a relative with adenomatous polyps also increases the risk of developing adenomas or CRC. Inflammatory bowel disease such as ulcerative colitis or Crohn's disease is also associated with increased risk for developing CRC. Finally, prior abdominal pelvic radiation also increases CRC risk. It is recommended that survivors of childhood cancer who received radiation therapy be screened for CRC earlier than the general population. Obesity, diabetes, smoking, alcohol intake, and red meat intake are modifiable risk factors for developing CRC. Now going to slide 19, we'll talk about prevention of colon cancer. Starting with primary prevention, practicing a healthy lifestyle by limiting modifiable risk factors is important in reducing the risk of developing CRC. Additionally, the USPSTF recommends adults aged 50 to 59 years who have a 10% or greater 10-year CVD risk and are not at an increased risk for bleeding and have a life expectancy of at least 10 years take a daily aspirin for the primary prevention of CRC. Now, slide 20 goes over the USPSTF recommendations, and slide 21 talks about the USPSTF recommendations again. So the USPSTF recommends that adults at average risk for CRC should be screened from age 50 to 75, and that is an A recommendation. Screening from 76 to 85 years should be an individualized decision based on the patient's overall health and prior screening history, and that is a C recommendation. Now going to the next slide, the American College of Gastroenterology has similar recommendations to the USPSTF, except that it recommends that CRC screening begin at age 45 in African Americans. The American Cancer Society makes a qualified recommendation that CRC screening begin at age 45. This is based on epidemiological evidence which shows colon cancer incidence is rising in people younger than age 50. There are various CRC screening methods. Colonoscopy is the gold standard. Colonoscopy should be performed if any of the other screening tests are positive. Surgical resection of the tumor is the only curative modality for localized colon cancer. After potentially curative resection of the colon cancer, post-operative chemotherapy is performed to destroy micrometastases. This reduces the likelihood of recurrence and increases the cure rate. Now going to slide 27, we'll talk about policies and laws. The Affordable Care Act requires private insurers and Medicare to cover the costs of USPSTF A and B recommendations, which would include CRC screening. There should be no out-of-pocket costs for patients for these screening tests. The CDC's Colorectal Cancer Control Program, or CRC-CP, aims to increase CRC screening in adults aged 50 to 75 who are members of in-need groups. It is currently partnered with 20 states, 8 universities, 2 tribal organizations, and 5 other organizations. The program uses provider assessment and feedback, provider reminders, patient reminders, and removal of structural barriers to increase screening rates. The Community Preventive Services Task Force, which evaluates evidence and makes recommendations regarding community health interventions, has made several recommendations to increase CRC screening. Some of these recommendations include giving patients reminders that they are due for CRC screening, one-on-one education at the doctor's office, providing reminder and recall systems, and reducing structural barriers to screening. And thank you for listening to my presentation.